Hello, this is it's Gareth Evans from the CTF conference in Monterey. Welcome everyone to this webinar. Hopefully I'll be able to answer any questions that you've got about NF2 and in particular I'm going to talk about the genetic side of NF2 and in particular testing of blood and tumor specimens, which can help us firstly in stratifying how badly affected or not so badly affected people might be, but also in terms of undertaking genetic testing on at-risk individuals in the same family. And in particular, what we know in NF2 is that there is a high rate for the first person in the family to be what we call mosaic, and that means that the gene fault that causes the NF2 actually started not in the egg or sperm that made that individual, but after the egg and sperm came together as an embryo. And because not all of these cells are affected in that individual, the risk of passing on NF2 is less than 50-50, which is the usual risk. So I'm going to take you through some basic slides to start with, and then some slightly more complicated ones, and hopefully I'll keep you with me all the way through. So you're probably aware that our genetic material is laid out on chromosomes, and these are our chromosomes. The biggest is number 1, and the smallest is actually number 21. And the NF2 gene sits on the long arm of chromosome 22 here. And the importance about DNA is that there is this coding sequence of 4 nucleotides, A, C, G, and T, and that 3 in a row represent one building block, one amino acid that makes the protein. And the reason you have problems with NF2 is when the NF2 protein isn't working. So the NF2 protein isn't doing its job in the cell to stop the tumor forming and the tumor growing. And so where it all goes wrong is where the NF2 code is damaged in some way, that it means the protein doesn't form properly. So when you inherit NF2, you inherit one faulty copy, but as you have 2 copies, like you have 2 chromosomes, you still have normal protein formed from the other copy. So you still have to lose the other normal copy before you get a tumor. And it might be that you have to mess up
Are you there, Dr. Evans?
number of yes?
Okay, all right, we just couldn't hear you there for a moment. Go ahead.
Okay, this is the number of letters in the code in your genome. So that's 3,000 million, so 3 billion code letters in the genome. And this is roughly the number of genes. So the NF2 gene is one of 30,000 genes that function. So obviously it's a very important gene, particularly for people who have NF2, but as well as everyone with NF2, there are around 1 in 1,000 people who will develop a vestibular schwannoma, or some of you might know them as acoustic neuromas in their lifetime. So for them, they've still lost 2 normal copies of the NF2 gene in their single tumor that they develop. And about 95% of people who get acoustics or vestibular schwannomas are actually sporadic, so they don't have NF2. And this is the number of genes that we know are important in the formation of tumors. So at least 300 of those. So NF2 is one of a smaller band where they're critical for the development of certain tumors. So those are the numbers to remember at the start. So it's not a lesson, but it's just, I think, nice to go through the figures so you've got some background. So the bottom line is that all tumors are genetic. That doesn't mean they're all inherited. It means that in order for a tumor to start to form, something has to go wrong with the genetic code. And in particular, there are 2 types of gene that are involved, what we call a tumor suppressor gene, where it's like the brakes on the cell, the brakes on the car. And then there's the oncogene, which is like the accelerator on the car. And the way it all works is if you inherit a mutation, say in the NF2 gene, one copy is already faulty, and the second copy is often just deleted out to end you up with no functioning copy in a cell. And these events are just things that happen when your cells divide. So you don't have to be exposed to anything for you to lose the second copy. It happens by chance if you don't repair it. There are things that can increase your likelihood of losing the second copy. Radiation, for instance, can damage DNA, and that's why we have some concerns about the use of radiation, because it might induce further tumors to occur by knocking out the second copy of the gene. Now, in order to get a sporadic tumor, a sporadic vestibular schwannoma, you need to be unlucky enough to lose both copies in the same cell. So that's a pretty unlucky event for both copies to be targeted and lost in a single cell. And that's why it's relatively rare for people to develop vestibular schwannomas. As I said, about 1 in 1,000 people will develop a symptomatic vestibular schwannoma in their lifetime, although more and more people are being picked up on MRI scans for other things and find out that they have a vestibular schwannoma, which might never have caused them any problems later in life. So the basic principle is that the NF2 gene is a tumor suppressor gene, and as long as one copy is working, one set of brakes is working, you can still brake that car. But if both sets of brakes have gone, that car has no control. Now, it may be you need to be on a downhill slope or have the accelerator pedal stuck down as well for that car to go out of control and to form a tumor. But the absolutely pivotal event is losing both normal copies of the NF2 gene. And there are many ways in which the NF2 gene can be lost or mutated. Most of the events start with a single change or a very small change in the letters of the code. Now, if you imagine that the genome is like a library of 30,000 books, well, the NF2 gene is a middle-sized book in the library. And it's divided into 17 exons, 17 chapters, and all of the known genetic faults occur in the first 15 chapters of the book. Now, most of the initial changes, like they are in the inherited form, are small, minor changes to the code, but they can completely screw up the NF2 gene. You can get whole chapters going missing from the code, and that's something we test for separately to actually looking at the sequence itself. And actually, very frequently, either the whole of chromosome 22 goes missing to form a tumor, or the long arm of the chromosome goes missing. And then there are some other rarer things which are a bit too complicated to talk about in this webinar. So the vital event, and actually yesterday was the 20th anniversary of the final publication of the NF2 gene in Nature, the Rouleau et al. Article. It was first, it came out in March, but the actual anniversary of the final code being found out was actually yesterday, so June 10th, 1993. And it was found by mapping families. Initially, what they were able to do was show that all individuals with NF2 in a family who had NF2 had exactly the same copy of chromosome 22, and they were able then to narrow down until they found the gene itself. And it's a middle-sized gene. It makes a protein that has 595 amino acids, and it's been termed Merlin the magician, or schwannomin, which is what the French group originally called it. Most people now call the protein Merlin. And it was an unusual structure at the time for a tumor suppressor gene, but more and more is being understood about it. And like neurofibromin, which is the NF1 protein, and like many other proteins, it is expressed in all tissues. So this is the structure of the protein, and there is what's called an N-terminal region and an alpha helical domain, and mutations really from the beginning of the gene through until about here will cause the protein to not work properly, whereas actually mutations further into the last part of the gene appear not to occur, or if they do occur, are probably harmless. So when we started out looking for mutations in the NF2 gene, and this is the first 564 families, we used a screening test to try and pick up the genetic errors, which was not perfect, and but it was difficult in those days to sequence. Nowadays you can sequence the whole genome in a few days. In those days it used to take 6 months to sequence the NF2 gene. So things have moved on enormously, and the cost of testing has moved down and down and down. So we undertook these early screening tests and then moved to sequencing in 2000, and we added a test called MLPA, which picks up these whole chapters that go missing in 2003. And in fact, we screened our 1,000th patient in October 2008, and we're getting on for nearly 2,000 patients that we screened in the lab in Manchester. And as I said, the mutations occur in the first 15 chapters of the book, and that they're really spread pretty evenly in those 15 chapters. And there are various types of genetic fault, which I will talk about slightly, because it does have an impact on how severely affected you are as to where the fault is in the gene, but also the type of genetic fault. So these were the distribution of faults. Now, a nonsense mutation is a mutation which leads to what's called a stop codon. So it stops the formation of the protein at the point where the mutation occurs. So basically there is no normal protein formed. And a frameshift deletion or an insertion is where you insert an extra letter or delete a letter or a combination of letters, and that leads to a shift in how the code is read, and that again leads to a stop codon and to the non-formation of the protein. And then you can get changes which cause less severe disease, because they may actually not very seriously disturb the protein. So something that just changes one building block, one amino acid, to another amino acid may be nearly harmless, or may only cause a very mild form of NF2. And then you get mutations called splicing mutations, which affect how the chapters are spliced together. And they can be very variable. Large deletions, and sometimes the whole gene itself is deleted, actually cause relatively mild disease. So we don't know for sure, but the first 3 sets of mutations are the ones that are associated with the severest type of NF2, and we think that in some way these faulty copies affect the normal copy of the gene. So you get something called a dominant negative effect. The other changes are less severe. So one of the things we found early on is that we had a reasonably high pickup rate when we screened families, and we screened the second person in the family. We picked up about 93% had mutations. But when we looked in isolated cases, the pickup rate's only about 63%. And I told you at the beginning, the reason for that is what's called mosaicism. So we're not seeing the mutation because it's not a high enough concentration in the blood to detect it. The other thing we noticed is when we went from our early screen to our better screen, you could see an improvement in the pickup rate of mutations. Now, when we look at families, and this was the first 112 families, as I said, we picked up 93%, and the distribution of the mutations is different. And that's because in families, in order to be fit enough to have children, you probably don't want to be having really severe NF2 by the time you're 18 or 20. So NF2 can affect, severe NF2 can affect the likelihood of having children. And so what we see are the milder mutations become more prominent where you're looking at the second or third generation of a family. And you can see the splicing and large deletions coming in here and the missense mutations being more common. So from a really early stage, we were identifying that these truncating mutations, these nonsense and frameshift mutations, gave the worst prognosis. There were significantly more meningiomas, the tumors of the lining of the brain, and also it had an effect on survival. The missense mutations almost give you a normal life expectancy and are the mildest category. And this has really been reported by many, many people, by the NIH group, by the Boston group, by the Germans from Hamburg, and by ourselves as well. And just to give you an idea how it can affect the age of onset, the truncating mutations give an average age of onset of symptoms of around 17 years of age and a mean age at diagnosis of 21, compared to missense mutations, which give you a mean age of onset of symptoms of 33 and a mean age at diagnosis of nearly 42. So that's a very big difference. And you do see far fewer tumors in people with these missense mutations. Again, as I said, that's the type of mutation where you just change one amino acid in the protein itself. And mosaic cases are milder as well. So when the mosaic case only affects the tumor, you get a similar age of onset to the mildest mutation, the missense mutation. So you're not seeing it in blood, you're only seeing it in the tumors. Now, we were very fortunate in the UK in that in April 2010, we got our service nationally funded, and we have £7.5 million a year that comes directly to us to run our service in England through 4 centres. So all the patients are coordinated in the UK, in England, which is just over 50 million people. All are seen and coordinated by 4 centres. That means we concentrate the expertise in those 4 centres. But it also means that we have a single lab that does all the NF2 testing, and that lab is thankfully for me, in Manchester. And we've done quite a few tests since the inception of the service, and we reviewed all of that up to December 2012. We've screened 374 patients in that just over 2-year period, looking at both blood and looking at tumor. Now, what's the benefit, you might say, of looking at tumor? Well, you might not find a mutation in blood if a patient is mosaic, because they haven't got it at high enough concentration. But if you go and look at the tumor, you can find the mutations in the tumor. And so more and more nowadays, when surgeons remove the lumps and bumps of NF2, they actually can do the test on the tumor by freezing the tumor, by extracting DNA from the tumor. But we actually find 2 hits, because both copies are faulty. So in order to prove which is the hit that caused the tumors to occur, you actually need to look at 2 tumors to see which genetic fault is the same in both tumors. Now, sometimes we go to the tumor and we find the change, and then we go back to the blood sample and can find the mutation at a lower concentration in the blood. And again, that has implications for children, because if we see it in blood, the risk will be higher than if we can only find it in tumors. So we've done 110 pre-symptomatic tests. So that's tests on the children of people with NF2. As I said, it's usually a 50-50 risk of passing it on because all your genes come in pairs. 1 copy is faulty, and it's like tossing a coin. So you could have 5 children and none of them could be affected, or all of them could be affected. But by and large, it works out at 50-50. Very occasionally, we still have to go back and do what's called linkage analysis in families where we can't find the causative mutation. And we do a few prenatal tests. So in that 2.5-year period, actually 3 people wanted their pregnancies tested for NF2, and occasionally people decide not to go through with those pregnancies. It's unusual, but in fact, in the UK, we do have people going for what's called pre-implantation genetic diagnosis, where the embryos are created outside the womb by IVF treatment, and then you only put in the embryos that you've tested that don't have the NF2 gene. And as I said, we've done testing of tumors, and what that enables us to do is improve the likelihood of finding the mutation. You can see that testing of tumors has allowed us to identify mutations where we wouldn't have identified them normally. And we've also tested families with schwannomatosis, with unilateral vestibular schwannomas, and we do occasionally find individuals who've had unilateral tumors just on one side at a very young age. They can have NF2. So I'm going to talk a little bit more about the mosaicism, because that leads into how we can assess the risk, the chances of passing NF2 down to your kids. So when we look at blood alone, we only identify about 58%, 383 out of 656, what we call de novo patients, so patients with no previous family history. We find the genetic fault in the blood sample. And if we look more closely at the blood sample, around 37 of those, we can identify the genetic fault at a lower concentration in blood. And that means we boost the detection rate up to about 66%. And then by looking at tumors, we can boost up that detection rate even higher. Now, where individuals present atypically, so that means that they don't present with bilateral tumors at the same time. They may have an asymmetric presentation. They might get their unilateral tumor in their 20s and then present 10 years later with a tumor on the other side. Then the likelihood of mosaicism is even higher. And so we have a lower detection rate in those individuals on their initial analysis of only about 40%. And again, we can boost that up by looking at the tumors. So we've now identified 125 patients with mosaic NF2, where the mutation is not in all of the cells, either from looking at blood or from looking at multiple tumor samples. We've now improved our detection rate in blood to 95% in the second generation. Now, we don't think there is another NF2 gene out there. We think that there might be other mechanisms that knock NF2 out in those remaining families where we haven't found the genetic fault. So one of the things we've looked at is these unilateral sporadic vestibular schwannomas, where individuals can present sometimes even in their teens with a one-off tumor. And we found only 5 mutations in blood, and all of those were under 21 years of age. So it's very rare to identify a fault in the NF2 gene unless the sporadic tumor is at a very, very young age. And we have identified some mosaic patients who developed unilateral tumor between 20 and 30. However, historically, we know there are other patients who presented initially with a unilateral tumor and then went on to develop NF2. And in fact, 45 out of 1,000 NF2 patients that we have on the database initially presented with a tumor just on one side. Now, that is probably an overestimation of what we would find now, because of MRI is so good that we can detect just little dots on the other nerve now with the 1 millimeter cuts through the meatus. So this gives you an idea of the likelihood. So if you present with a unilateral tumor under 20, there is about a 9% chance you'll find it on blood, and there's also around a 20% chance that you'll have NF2. The remaining 11% are mosaics. If you present between 20 and 29, there's around a 0.7% chance you'll find something in blood, and overall only around a 1 in 30 chance, 3.3%, that you'll have NF2. And beyond 30 years of age, we really don't think that it's worth worrying about NF2 because the risks are well below 1 in 100. So again, this is our updated list looking at the mutations, and you can see here that the nonsense mutations are still top of the list with 19 missense mutations now, so that's we've really picked up on those recently. And you can see here again the split in the families. The truncating mutations are lower down the list. And where we have missed cases, there are 6 families that we couldn't pick up. We did send some blood to Ludwig Messier in the States to look at RNA, and she did detect 2 out of the 6 with that technique. But it's rare that we have to look at RNA to find the genetic fault. So I said I was going to give you a bit more detail on the risks. So if you're someone who's got NF2, you've got no family history, and you've got kids, and they've done the blood sample testing on you and they haven't found the mutation, what's the likelihood that you'll pass it on? Well, if you're diagnosed under 20 and you've had bilateral tumors on your first scan, it's unlikely that you're going to be mosaic, but it's still possible. And in fact, overall, around 12% of people in that category still have a mosaic form of NF2, but the likelihood of you passing NF2 on to your children is very close to 50-50, not quite 50-50. If you present with a unilateral tumor under 20 but still have NF2, then there's actually around a 32% chance you're mosaic, and the chance without having tested blood is about 36% that you will have an affected child with each pregnancy. Now, if you go to the other end of the scale and look at a 40-year-old, someone who presents after 40 with bilateral tumors, there's actually a 70% chance that they will be mosaic. And even without testing the blood, you can already reduce the likelihood of them having children down to 1 in 5, 19%. And if you present asymmetrically, again with NF2, but you started off with a unilateral vestibular tumor, even without testing blood, you can say that the risk has dropped to 1 in 11 of having an affected child. Now, after blood testing, you can be even more accurate, and you can really reduce those risks down, because if you don't find a mutation in blood, it's unlikely that it's a missed mutation. It's much more likely that they're mosaic and it's only detectable from tumor. So even in the highest risk situation of presenting at a young age with bilateral tumors, if blood is negative, the risk of you having an affected child has dropped down to 27.5% with each pregnancy. That's 1 in 3 to 4. And at the other end of the scale, if you're over 40, it drops down to 1 in 14, or 7%, or even less if you present with a unilateral tumor. So we've now just recently published our protocol for how we go about testing of individuals and their family at risk. And it sort of covers the idea that we would continue to think that someone might be at increased risk until their likelihood of having NF2 dropped below 1%. So group A is our sort of higher risk group, and that's obviously individuals who have a risk of NF2 or mosaic NF2, and at least a 5% chance we would find something on a blood sample. Now, this is the sort of patient, someone who presents with an isolated unilateral tumor under 20, an isolated meningioma under 20, childhood isolated schwannoma at another site, and many individuals we see with NF2 have had, a lump removed from their skin when they were 5 or 6, and when you go back to the pathology, it was a schwannoma. And so that is a frequent finding. The other thing more and more that we're finding is that people are being diagnosed with NF2 on the basis of an ophthalmic surgeon looking at the eyes. You get really typical features sometimes with NF2 in the eye, something called a retinal hamartoma, which is a benign, harmless change at the back of the eye, and also you can get early cataracts. So more and more we're getting people being referred to us and they're saying, oh, this person's got, this 2-year-old child has got a hamartoma, we think they might have NF2. And in fact, there's a high rate of picking up those individuals on blood samples. So the other category is individuals who have at least 2 criteria from the Manchester criteria under 50. So say a unilateral vestibular schwannoma and a meningioma, or a unilateral vestibular schwannoma and a childhood mononeuropathy. So these are people that we think have a relatively high chance of having NF2. So what we do is we do a mutation analysis on the blood and the tumor if possible, and if they're negative on blood, we still follow them up because of the possibility of mosaic NF2. And that's our protocol for following people up every 5 years with MRI scans. Now, Group B is the lower risk group, so below a 5% chance of picking anything up on blood, so they presented later with 2 NF2-related tumors or a unilateral tumor aged 20 to 30. And then we can do, again, the blood testing, but if they're negative on blood, we would only follow them up for maybe 20 years with MRI. But the main thing that probably most of you listening are worried about is what about your children if there isn't a blood test available, and if there's a 50% risk, then it's fairly straightforward. You do the gene test, and hopefully you can then have a definite yes/no answer as to whether they've got NF2. If the risk is less than 50%, as I've shown you, if you're the offspring of an isolated case of NF2. Now, what we think is worth doing is if the risk of mosaicism is very high, you can still do mutational analysis on the unaffected individual. Obviously, you start, if you can, with the person who's actually got NF2 and try and find the genetic fault. But where tumors really come in handy is that in most situations, if you look at a tumor, you can come up with a test for the children. You may not even need to identify both genetic faults in the tumor, because you can see you can get the green light here if you identify both mutations, a point mutation or 2-point mutations, a point mutation and an MLPA. But you can actually do the test if you only find loss of 1 copy of the gene, because that will be the normal copy. And if the child has identified the normal copy of a gene, the one that goes missing in the tumor, you can then reassure that child that they haven't got NF2. And what we do is we combine the risks that we calculate with the likelihood of picking something up on an MRI scanner. This is the likelihood that if you do MRI scanning that you will pick up NF2 on the first scan. So by 20 years of age, nearly 80% of NF2 children will be picked up as having NF2 on a scan. And you can then use this reverse category where you start at 50-50 risk, your risk drops and drops and drops if you haven't had NF2 features and if you're negative on an MRI scanner. So we think at the moment that formal screening for vestibular schwannoma should start at 10 to 12 years of age, with MRI screening every 2 years until they're 20, and then it can extend to 3 to 5 yearly. Now, this is for someone who hasn't got NF2. Once you've got NF2, you obviously have much more frequent follow-up. And we would discontinue MRI at 40 years of age, except in rare multi-generation families where we can't find a mutation, but it's relatively mild onset. And so this gives you an idea of how you can use the MRI scan. So for instance, at 20 years of age, you can actually reduce their risk by 2.5-fold. And if they started with a 10% chance of NF2, you've already dropped it to 4%. So by 30, someone with an initial 10% risk, you've actually reduced their chances of NF2 to 1% with a normal MRI scan. So I'll give you some examples of this. So a child of an isolated parent presenting with bilateral tumors over the age of 40, a quite common occurrence, but a blood negative. The risk to the child starts at 19% prior to testing the parent, and it drops to 7% if the parent has tested negative on blood. And that you can see from this chart here, starts at 19%, drops to 1 in 14. And if you put that in the divisor here, that person can be discharged at 30 if they've had a normal MRI scan. The likelihood of NF2 is so small. So, the other thing you can do is consider testing in the child. So there's a 4% chance of a missed mutation in the parent would mean a 2% chance of a missed mutation in the child. That's because you may have missed the mutation in the first place rather than it being mosaic. And so testing of the child actually means that you could withdraw the MRI screening at 25 years of age because you'll have ruled out essentially most of the risk. So the second individual is a child of a parent presenting with bilateral tumors at 25 years but blood negative. The risk to the child is 16% on the basis of a negative test. Because there's 25% chance of a missed mutation in the parent, we wouldn't therefore do testing of the child because it wouldn't really reduce the risk enough for us to discontinue the MRI screening. So here's the situation, 16%, 1 in 6 risk here of someone whose mother or father had bilateral tumors in their 20s. And so again, just going to the divisor here, we would actually continue to follow that individual up on scanning until they were 35. So what we've now been able to do with these guidelines is come up with a way of being able to, in nearly every situation, offer a risk of what the likelihood of NF2 is for your children, your brothers and sisters. Now, if you're mosaic, it means that your parents can't be at risk and your siblings can't be at risk because the mutation occurred after the egg and sperm came together. So I'm not sure how we go from here. I left quite a lot of time for questions. I don't know if there is a question and answer forum, but if there isn't, I can talk for another 20 minutes around the area of genetics.
We do have
Dr. Evans.
Are there any questions?
Yeah, we do have some. Let me read you a couple of them that have come in.
Yeah.
This one is from Marie, and she's asking about personalized and precise medicine. She said, how important and how available is the testing for your precise mutation and the knowledge of the best drug then to treat it?
Right. Well, at the moment, we don't have a situation where the type of mutation can tell you which drug to treat that person with, although there are certain rare types of mutation where you can get some sort of what's called a morpholino to read over the mutation. So if you have a cryptic splicing mutation, for instance, in the intron, and I said that there are 1 or 2 of these that we've found, you can actually get a morpholino to anti-sense that, to stop it doing its splicing, and that patient would be cured by that treatment. But it's very individualized, very tailored. You've got to design the morpholino for that individual. We think that it might also be possible with certain splicing mutations if you can lose one chapter of the NF2 gene in frame to again treat that person with something that reads over their splicing mutation, and they end up actually with a not full-sized NF2, but one that may work better than the one that they've actually got. So those are really the only situations at the moment where we've got this sort of potential for personalized medicine. That's exactly what's being used in Duchenne muscular dystrophy. And there are certain mutations there where you can do without one exon in the gene, and they're having great success with it. So we are at the beginning of that. There's also an idea that you can use certain things to get nonsense mutations to read back, although again that's not really been tried to any extent in NF2 so far. So in terms of personalized therapy in NF2, it's more about being able to predict how badly affected someone's likely to be from their genetic fault, rather than being able to use information about the specific genetic fault to develop a treatment. Now, obviously, when the genes were first discovered, we thought, well, hey, if we can just repair the fault, then that person will be better. In practice, that means actually replacing the faulty copy of the gene with a normal copy. And that has proved very difficult. That the delivery, we just can't get the normal copy into enough of the cells to make it work. So in cystic fibrosis, for instance, the gene therapy, you can get it into the lungs, and that's where the problem is. But even in the lungs in cystic fibrosis, you can't get enough of the cells with the normal copy to make the difference. So, you know, it has been disappointing that since finding the gene 20 years ago, that there hasn't been this breakthrough other than what I'm talking about, these rare instances where you can use this antisense technology to potentially design a treatment for that individual and that family. So is that, have you got another question for me?
Yes, I sure do, Dr. This one is this woman's name is Jamie. She's a tumor of mine was tested, and the genetic mutation for NF2 was found in it. Mine is a mosaic spontaneous mutation. The same change was not found in my blood, nor in another flat muscle tumor that was tested. I'm 47 with low tumor load, not diagnosed until 40. My children have had their blood tested. My mutation was not found. What are the chances of a false negative? They are 8 and 11 with no signs of NF2 in the eyes or other visual, physical, or hearing tests. No scans have ever been done of their heads.
So what I would say is that if they only found one mutation and they didn't find the second hit, and they looked at a second tumor and they didn't find the mutation that was in the first one, the likelihood is that the mutation is actually the one that wasn't found in the tumor, the second hit. So unfortunately, I'm not sure I've got you right here, but if you had two tumors tested and you only found the mutation in one of them, it's unlikely that second tumor, if it was a schwannoma, was a chance schwannoma in someone who's got NF2. So, but you did say a muscle tumor, so if it wasn't an NF2-related lump, it's still possible that the mutation that was found is the underlying one, the mosaic one. But I would be concerned unless both faults were found in the blood, that this might be a situation where the negative test for the mutation is misleading, and it might be a false negative. So again, I would need more information about the testing to be able to give you a definite on that. But the fact that they haven't got symptoms is reassuring, but I certainly would want them to have an MRI scan to be sure.
No, thank you, Dr. Evans. Now I have another question here from Mike, and he's actually asking, can you have both NF1 and NF2?
So yeah, that has been described before, but unfortunately, there are still doctors that make that diagnosis, because some people with NF2 have quite a lot of skin tumors, and they may even have quite a few cafe au lait patches. So it's very, very rare that you could have both, particularly if you don't have two affected parents. So there has been a case described of a mother with NF2 and a father with NF1, and the child had both the NF1 and NF2. So you would have to have a fault in both genes to have both conditions, and that would be extraordinarily unlikely if neither of your parents were affected. So to give you an idea of how unlikely, around 1 in 5,000 people are de novo, they have a new mutation for NF1, and around 1 in 60,000 have a new mutation for NF2. So that means that it's actually 1 chance in 180 million that you would have both NF1 and NF2 as a de novo event. So it would be extraordinarily unlikely.
Wow. Wow.
But that means that there could still be 1 person in the United States, or maybe 2, that could have both NF1 and NF2. So if you look at it the other way around, there's 300 and something million people in the US. That means there could be 2 people out there.
Thank you, Dr. Evans. Here's another question. My son is a spontaneous case of NF2. He's 17. My husband and I have brain MRIs and are fine. I have another son. He's 15 now, and he has not had any tests at all. The doctors say since my oldest son was spontaneous case, my other son would not have NF2.
Yeah, that's very likely the correct situation. In fact, we really haven't seen families where you've got two affected siblings and no affected parents. But there is a very small chance that there could be a patch of egg or sperm producing cells that means you don't have full-blown NF2 yourself, but could still pass the condition on more than once. Now, in reality, if you've got no features of NF2, it's unlikely that you will pass the condition on more than once. So I would consider the risk to your unaffected son as less than 1 in 100. But if you wanted more complete reassurance, you'd need to have your affected child tested, find the mutation in your affected child, and test your unaffected child to show they don't have that mutation. So that would be the only way you could get 100% reassurance. The moment it's probably greater than 99% that your son doesn't have NF2.
Wonderful. And this question is from Nicole. She said, I have had blood testing and it has come up negative. Should I still get tumor tests to see what the risk is of passing it on to my children?
Yes, I mean, I think that is the ideal, to test tumor. Now, the problem is unless it's been saved, like it's been frozen at the time of removal, the tumor that's available might not be good enough to do the DNA testing on. So what you would need to look at is the possibility, if you have a skin lump that is a schwannoma in your skin, you could have that tested. So you wouldn't need to have a major neurosurgery just to get a test for your child. And I found that's very, very successful, just taking a little lump out of a skin lump, and you can do the testing on that. And I've found the genetic fault in many individuals by doing that. The other possibility is if you've had a tumor removed, you could still do what's called the loss of heterozygosity study on the paraffin block that will still be in the pathology lab. And that would mean there's a 50% chance you could exclude NF2 in your child by showing they hadn't got the copy that went missing in the tumor, as I sort of described in my talk. So yes, I think tumor testing is the way forward to come up with a more definite answer for your kid.
Okay, now this question is from Kim. She says, I have been diagnosed with mosaic NF2 with a nonsense mutation, low level found in my blood. Is that the most severe mutation at a low level? What does that mean for how it might progress?
So you will still be milder because the mutation is not in all your cells, but having a nonsense mutation that's detectable in blood means that it's probably in around 10 to 20% of your cells. So it still can cause a moderate type of NF2, and you can still get lots of tumors on that basis. So what's more concerning is if you pass it on to your child will be more severely affected because their fault will be in all their cells. Now, with a nonsense mutation, it does depend where it is in the gene. If it's in the first 8 or 10 chapters of the gene, then it tends to be more severe. If it's in the last few chapters, in chapter 13, 14, or 15, then it actually causes much milder NF2 with a nonsense mutation. So actually where the nonsense mutation is can still be important as well.
Right, and this is a different Kim. She's asking, is there any link to pesticides and insecticides to spontaneous mutations?
Well, I don't think we know that for sure. You know, in order to get spontaneous mutation, you would have to have your egg and sperm cells exposed to something that damages DNA. And I don't think there's been any absolute proof that those sorts of things would actually induce a spontaneous mutation. So even people who are exposed to chemotherapy, there doesn't seem to be a higher rate of new mutation. So I wouldn't be particularly concerned that that was a cause of new mutation.
Okay. And this is another question that the same mom has here. Can you talk more about sporadic mutation? Son was diagnosed at 24 years, no NF2 in the family. When would his mutation occurred?
Well, around, as I said, in terms of the NF2, around a third of people who are spontaneous mutations are mosaic. So the mutation occurs during development as an embryo, so it's not in the egg or sperm. The remainder, it's likely to be a one-off change in the egg or sperm that made that individual. So when that egg was created, the NF2 gene fault occurred, or when the sperm was created, the NF2 gene fault occurred. So as men get older, they're less good at repairing the DNA in their sperms, and the chances of a spontaneous mutation increase. So theoretically, if your father is older, there's more chance of there being a spontaneous mutation.
And this one's from Yolanda. She says, my son was diagnosed at age 10 with NF2 with a brain MRI, but he does not have a genetic test. Is there a hospital or a center that will take his blood and send it to Manchester? Is there any place that you would recommend in the United States?
So there are a number of labs in the United States. Birmingham, Alabama is probably, that's Ludwig Messiaen's lab there, is probably the one to go for. Yes, obviously we can do the testing in Manchester as well. We can, as long as we get a blood sample within 5 days, we can do the testing in blood. Or you can send DNA to us. And I think our charge at the moment is about $700 to do the full NF2 testing. So that's certainly possible to do. You would just need to arrange for someone to take the sample and send it, but obviously there would be a reimbursement issue in terms of the cost of the test. But Birmingham, Alabama is your sort of best place in the States to get the testing done for NF2.
All right, Dr. Evans, I've got one more question here, and this is from Susan, and she says that I have mosaic NF2 based on the diagnosis of a mosaic ring chromosome 22. She's asking if you could talk about the relationship of ring 22 to NF2.
Okay, so sorry, is the person themselves got ring 22 or their child has?
She does.
Okay, so the reason you get NF2 with ring 22 is that the chromosome is unstable, so it frequently gets lost when the cells divide. So the NF2 gene is rarely lost in the ring 22. So if you look at the NF2 gene, it's normal, so you have two normal copies. But unfortunately with ring 22, it's an unstable chromosome and it gets lost in the cell. That means you've already got mosaic loss of one copy of the gene because of this instability of the 22, and then the second copy gets mutated. So it's very frequent for people with ring 22 to have bilateral vestibular schwannomas or multiple meningiomas because of this instability in the ring 22. You often tend to get cafe-LA patches on the skin as well with the ring 22, so there are features that might get you misdiagnosed as NF1.
Well, I
think one of the fan club had a question. Barbara?
My question was, can it skip 2 or 3 generations?
Okay, Barbara was asking whether NF2 can skip 2 or 3 generations. The bottom line is if you don't inherit the mutation, it can't suddenly reinvent itself. So it cannot skip the generation. You either inherit the fault or you don't inherit the fault. Now, you will have the odd family where there are 2 isolated cases with NF2, but then they'll have different mutations. So, this isn't the type of thing that skips generations. Genetic changes are either inherited or they're not.
Well, are there any more questions there from the fan club, Dr. Evans?
Any more questions from the fan club? Sheila's got a question.
In a service-translated protein frame shift
Deletion, yeah?
deletion at, say, point 1562. Would there be any benefit, or has anyone looked at treatments to with amino acids to compensate for the missing amino acids that are not being made by the
So the question was that I think a lot of the question was picked up that whether you could use amino acids in some way to treat. What if you get a frame shift mutation? The problem is the protein isn't formed properly. So I guess if you could try and get it formed properly, that would be great. But unfortunately, there isn't really a treatment that's been developed yet that can use amino acids in some way to try and replace the bits that are missing. So there has to be a way of either getting that frame shift deletion to repair itself, which we haven't found a way of doing, or getting the normal copy of the gene back in the cell. And so at the moment there isn't really a solution for that type of genetic fault. So for nonsense mutations there may be a way of getting it to correct itself, and there may be a way for these splicing mutations of finding a way around it with this missense antisense morpholina.
Well, thank you, Dr. Evans. You know that some people idolize rock stars, and for those of us with NF, we adore our NF researchers. So to us today here, you are our rock star. Thank you very much.
Thank you. Thank you. Yay! Thank you from sunny Monterey.
And you'll be able to view this presentation in a couple of days on our website. It'll be posted. And after this webinar is finished, a survey is going to launch and pop up on your screen. And we greatly appreciate if you take a few minutes to complete the survey, because our participants' thoughts and suggestions are really helpful in preparing for future webinars. The NF
Okay, that's fabulous. It was all very good for me. Okay.
Good.
Thank you.
We'd
Bye.
like to thank you for making the webinar possible. Thank you for everybody
No problem.
attending this evening.
Okay.